And hello, everyone. TJ All, it's I-45 now and 288 now and Galveston now with another edition of UTMB Healthcare Unmasked. And a very important topic we're going to be tackling today is combating opioids as well as the fentanyl poisoning epidemics that are crossing the entire country, but we're seeing a lot in Texas and our local market. We'll be talking about that, and we'll be talking to you from our new studio here at UTMB Health. It's been set up, and we'll be able to have our guest on live with us a lot of times going in there. And without further ado, should bring up our guest for today's show, Dr. Kathryn Cunningham, who heads up the Center for Addiction Research here at UTMB Health. Thanks for coming on with us. We appreciate it.
I really appreciate the opportunity to talk about this incredibly important problem.
And it is something that has made the headlines in a lot of places, and not just when we're talking about headlines of poisonings or that we're seeing happening elsewhere in the country, but we're seeing problems right here in our own county, our own region. And it's one of those things, before we get into kind of to explain what fentanyl is, as you look at this, you said something in our pre-interview the other day that I thought was very interesting. You said you and others have been worried about this for some time. And right now, it seems like that the country's conscious on this is just now catching up with the concerns y'all had.
That's correct. The fentanyl problem is just escalated dramatically in the last couple of years. And Texas was sort of not at the top of the list compared to the East Coast and the West Coast. So we are a little behind, and we're playing a bit of catch up now.
Yeah, it is one of those things that we'll be touching on throughout the day here. We've got some special guests that'll be coming on as well with us as well. And we'll get going with that show here in just a little bit. We're going to be taking your questions as well throughout the show, so make sure you join it after we have these words from UTMB Health.
UTMB knows when you're expecting, you may not know exactly what to expect. From that first embrace to all the milestones that follow, we know how important each stage of life is. That's why UTMB Health's obstetrics and gynecology physicians specialize in innovative women's health care through all phases of life. UTMB knows women's health. UTMB knows you. To find an OBGYN specialist near you, visit utmbhealth.com/women's.
And welcome back to the show, UTMB Health's Healthcare Unmasked, and we're talking about opioids and fentanyl poisoning here. And Dr. Cunningham, let me start with you. And for those of you just joining us, Dr. Kathryn Cunningham heads up the UTMB Health Center for Addiction Research. And you have some, I would say, surprising numbers, and I would almost say sobering numbers on this. But let's first talk, because people will hear the term about synthetic opioids or fentanyl. Just what exactly are we talking about here?
So morphine and heroin are both derivatives of the opium poppy, which grows in several places in the world. But back in the late 70s, early 80s, synthetic opioids were designed to remove the need to find an opium poppy to treat pain. And so some of the earliest synthetics include fentanyl. Fentanyl is one of the very easy derivatives to make, but it's one of probably hundreds of possible synthetic opioids that could be made. And many of these are showing up in street drugs right now and in pills that look like prescriptions, but they're actually counterfeit.
And in fact, let's take a look at, this is one of the things you provided. You give us the breakdown on this slide here of what makes up the fentanyl and fentanyl analogs. Also explain the difference again between what fentanyl and fentanyl analogs, because that gets really kind of technical, but there's an important difference between the two.
Fentanyl is a prescription drug that's used frequently in surgery for severe pain. Fentanyl was developed as a small molecule that could be produced in a chemistry lab, and it is still a prescription drug that's used today. However, it's a very simple molecule, and there's a picture of that molecule on this slide, and that molecule can be crafted in many, many ways by just changing, like a Lego building, what you want to add to it. And for the DEA, the Drug Enforcement Agency, and the folks that are the folks that schedule these drugs. And Schedule 1 is there's no abuse liability. There's no, it's high abuse liability. Schedule 2 allows compounds that are abusable but can be used in surgery, for instance, such as fentanyl.
It all it takes is a little bit of an adjustment to avoid the law in this case.
That's the other piece.
And that's the tough thing, is that the law can't keep up the pace sometimes, right?
That has been a problem. The DEA has been very diligent about creating and following all of the seized drugs that they pick up. Once those drugs are seized and they analyze them and figure out what the structure is, they quickly become Schedule 1, which makes them illegal to possess.
Chemistry is chemistry. Yeah, is what it is, and making laws that can combat that. It's you can barely get some laws out within a couple of years to keep up with that. Goes along the line as well. But I think it's important to note here as well is that when we're talking about fentanyl and we're talking about opioids, we're not talking about, oh, hey, this is, grown for just one particular reason or made for one particular reason. They're actually good reasons to have fentanyl and opioids, and that gets lost on some people. What if you could explain, how that is, because when under control, under the direction of a physician, for example, it's that these are safe, powerful, but safe to be used.
They have been safe to use. I think this crisis that we're in right now has really made all of us think, and especially physicians think, about when do we prescribe opioids and what conditions and what schedule and how do we follow them. For instance, we know that Narcan, here's a box of it here, Narcan can reverse the effects of opiates, but it was not until recently that it was made clear that when someone gets an opiate, they need to get a prescription for Narcan, which now is happening.
Yeah, and matter of fact, we've been showing there's one place in all of our region right now where you can get this. Doesn't cost you anything. It's at Hart Pharmacy in Lamarck, but you're trying to see an effort of getting that even wider distribution for no charge. But that's the tough part right now, is it not?
Yes. And Galveston County is an amazing entity. The coalitions here are phenomenal. The entities in the community at UTMB are coming together to actually make sure that Narcan's available in schools, in places that at treatment centers, and that everybody has a chance to learn how to use Narcan. It's straightforward, saves lives, but there's a couple of things that need to be, we'll talk about that later.
Right. And now where we get the problems coming in is when we're talking about overdose deaths and the like, because now what's happened, what was supposed to be a product when regulated by physicians, when used in treatment, works well and is safe, but it's what happens when someone is out and out of medical care, and then that leads to deaths. And in fact, the stats on this are pretty staggering here as we're taking a look at.
I think you have that slide up now, right. And what you can see is it's across time and year by year, and what you can see is this escalating. This started in about 2015, 2014 with prescription opiates, and has escalated into a serious public health issue because fentanyl and fentanyl derivatives are being tainted into drugs like cocaine, powdered drugs like cocaine, methamphetamine, and they're pressed into pills that look like a pill that someone might take, such as Adderall or Xanax or an OxyContin.
Right. And so, and that's the big problem, because as we had a recent session with the head of the DEA office in the Houston, Galveston area, and he explained to everyone is that, the folks that are making these pills don't care about you, really.
They're trying to make money.
Yeah, they're trying to make money, and when they do so, they mix it in here, and what you think if someone would take it, not you personally, but someone would take it as something that's safe, turns out it's not at all.
And an interesting question is if someone is making an incredibly potent fentanyl, they don't really want to kill their drug users. So I think it's a bit out of control in terms of what's going into these powdered street drugs and also counterfeit pills. Are they measuring it? I doubt it.
Yeah, no, they're just making sure it gets in there. And when we talked about, the number of folks who have died of the overdoses and also the fentanyl poisonings, there's been waves of this. And can you explain? Because we're showing a chart right now for our viewers too, where we talk about the waves of drug overdose epidemic in the United States here. And tell us what we're looking at here.
So on the far left is the beginnings of the pandemic. That gets mixed up. The epidemic that started with overuse and prescription of legitimate painkillers, and then that emerged into trying to get street drugs that were legitimate painkillers, and then that evolved into this. I still can't believe this curve. It's so dramatic, such that in this third wave we have even higher and higher deaths and continuing deaths with the fentanyl derivatives lacing street drugs. And many of these drugs they're not pure fentanyl. It's just the potency is so high. And if they're laced with cocaine and somebody thinks they're snorting cocaine, they're snorting fentanyl, a very potent, very, very dangerous drug.
And also too is that when someone is taking one of these pills, let's take the extreme out of just of cocaine use, because we're going to talk about this a little bit later, because the stigma that talks about. But what folks may be thinking that this is just a drug that I'm taking here, that it's not fentanyl, it's not bad for me really, it just makes me feel a little mellow, but it too can be laced with fentanyl and enough that can cause real health issues.
Yeah, especially the counterfeit pills. They look like what is actually a legitimate prescription drug, and unless you look very closely, you cannot identify that it is not an actual pharmaceutical. They're made to look like pharmaceuticals. So someone that's buying one on the street needs to be able to identify that, needs to be able to know what is in that compound, it is in that pill. So no, sometimes you can't tell. And I have a couple pictures later on.
And let's go ahead and take a look here too. The overdose deaths that have increased amongst age groups here. This goes into something, because I think a lot of folks in our age range think, oh, this is a kid's problem, and anyone younger than us. But it really isn't. And we're looking at a chart you put together here about how the increase has had in age group breakdowns between 2019 and 2020. Just 1 year. 1 year.
1 year.
And I was remarking here as I look things, and for those who are watching, that blue bar you see going up, that's 2019, and then the green is 2020 going in there. But that, the thought is, oh, these are kids, these are teenagers and the like. But the largest group is 35 to 44 in there. And then it's 25 to 34, kind of second place, if you want to call it. So really what we're talking about is where these are happening is folks that we would consider, hey, you're smart, you're out there, you're working, and you're contributing, and that the others people are having this problem. But that's not the case when you break it down by age, is it?
No, and the CDC just released numbers that said the U.S. Life expectancy has now dropped to the lowest rate since 1979 or 76. I can't remember. But it's in part because of these street drugs, and it's also because of COVID. So we can be expected to live a lot shorter period of time the younger we are right now. So it is impacting everything about what we think of a country like the United States. We are evolved, we're sophisticated, We have healthcare opportunities. So it really kind of challenges you mentally to think, how do we deal with this?
Right. And in fact, one of the things you can look at now too, folks, is that when you look at things of how the overdose deaths have increased, not is one time we were talking about only certain parts of the country.
Mm-hmm.
Now, as you look at this other chart you did here, that it goes from certain states to now it is almost, this looks like an election map.
It does
to me,
unfortunately.
When you take a look at 2019, 2020. Explain what we're looking at here, because you have the shades, I call them the shades of orange here,
Mm-hmm.
but of what the difference is that we're looking at here.
So these are derived from CDC tracing of seizures and of overdose deaths in the country, and these are just snapshots. But I picked these two snapshots to demonstrate how the situation has changed across time, but also to see what's happened in Texas. Texas used to be the color, the light orange on
Mm-hmm.
the left. It is now full on orange, as has been the East Coast and California.
In Texas is really, this is one area you don't want to be leading in, I would say, but Texas
No.
is up there.
No.
Right now, is it not? It's just, it is amazing to me when you see that and you think about, there are people who just want to say, oh, Texas doesn't have a problem in this, but it's really, really, really telling how much of a problem there is Texas. And we're going to talk about how to combat that here in a little bit as well. But we're going to take a look at this and it may be a little small for some folks, but we're taking a look at this is kind of a breakdown of the counties in the state that in Texas and in 2020 here. You got two highlighted at the top. Tell us what those are.
So the state of Texas tracks overdose deaths, and these numbers actually reflect 2020 numbers. Those are the most recent available online. And what we're looking at is the overdose deaths, drug overdose deaths, not identified specifically with what drug in this graph, but all those people that died of drug overdoses in Orange and Galveston County are at the top, and that is per capita. So that's the number of deaths per 100,000 population. Now, Galveston and Orange have smaller populations than Harris, but that graph illustrates that Orange County and Galveston County have a loss of lives that, in terms of per capita population, than does Harris County. Now, I will state that these numbers are as good as our tracking. Right? So we need to make sure that the tracking is correct. And that is one of the challenges that we have in the moment. Right.
And it's recognizing the problem before anything else.
Mm-hmm.
And then also too, we're taking the thing, and now we're going to take it even close of South Texas fentanyl seizures, because obviously, it's an easy drug to make. That's one of the reasons it's appealing. But the seizure rate is, if we're seeing these, that means it's coming across one way or another. And then if you're looking at the seizure rate, how much is it increased over 10 years?
So it used to be that fentanyl was flown in, mailed into the United States as a product, and it seems now that the precursors for making fentanyl are bulk shipped to the cartels in Mexico, and then the drugs are made there, and we are seizing them as they're getting across the border. How many, what percentage is coming over, and what percentage of this? I mean, is that all? No, because a lot of it is still getting into the country.
It is one of those where we talk about it in these situations is what we know has been seized, or what we know in the overdoses, but there's probably, how much, what would you say was the real problem there? Is there any guesstimate of what we're really looking at there?
I think the deaths that are happening is a pretty good estimate that it is getting into our country, and there are labs reportedly in the United States that are making it as well.
And for those that you're just joining us, Dr. Kathryn Cunningham, the head of UTMB Health's Center for Addiction Research, and we're talking about opioids and fentanyl. really in the headlines for a while with the opioids. I think a lot of folks had thought when the federal and state lawsuits and criminal trials had taken on with the opioid epidemic, that once that was done, that we didn't have a problem anymore. But really, that was the tip of the iceberg as far as the problem was concerned.
It's almost an opportunity for drug dealers, for chemists, synthetic opioid chemists, to take the place of what was a freer flow of prescription drugs. Now that has been tightened up, for those that need them for pain, chronic and severe pain, it's become an opportunity, and we're seeing the outcomes of it now.
And in fact, this was an interesting chart I wanted to bring up for everyone here. Is that you're in these vials that you have here? Is that you just said fentanyl's cheap, easy to make, easy to transport, but it's 50 times more potent than morphine, 100 times more potent than heroin. And what we're looking at with these vials here, because you have heroin there, you have fentanyl.
It's called carfentanil.
Carfentanil. And you can see clearly the white there in that heroin.
So heroin's lethal dose is about 30 milligrams, and that's represented by the white substance in the small bottle. Fentanyl is lethal at about 3 milligrams per kilogram, and that's the difference between 30 and 3 mgs per kilogram. And then the most potent of all, carfentanil, which is an animal tranquilizer, was sold as an animal tranquilizer, is we can't tell, but it's somewhere, quote, less than, what did I put?
1 milligram?
1 milligram. Barely detectable.
Yeah, I mean, you'd have to zoom in on that, and you see the little couple of grains there.
Mm-hmm.
And again, when we're talking about fentanyl, this was a thing I had gone when I was at we had a session with the Alliance, the Bay Area Family Alliance. And the interesting I heard there is that, what we're talking about with fentanyl is a few grains of, like, you compare it to salt in some ways, just a few grains of that in your system can be lethal.
That's right.
And in many cases, if it's not lethal, it's come very close to that for it as well. And like you had said, the opportunities that created when there was a crackdown on the opioids, it opened a new market. And this is the one thing I think that a lot of folks miss a lot of times in this is that is drug manufacturers, meaning the illicit drug manufacturers that are out there, work on a market system like any business does. The difference is that their stuff's illegal.
It's an enterprise.
Yeah, it is an enterprise, and so they're always looking for sales opportunities. They're always looking for a way to make a product, quote unquote, better, even though we would argue that about it being better, but that they make a more lethal product at the same time. That the risk that goes with that goes dramatically up. And because a little bit goes a long way in this case, they're able to distribute it at a wider audience out there for folks as well. So that's one of the things that you have to look at. And you brought up this headline too, and I should point out too, for example, we just had in the headlines yesterday the young man who played, on NYPD Blue, played the young Sipowicz, and there he was 27 years old. And it was a fentanyl poisoning of how his sister, went online to do that. But then, this is hitting in Texas's backyard, where we have 13 to 17-year-olds in Dallas overdosed, and there was 10 of those. 3 of them died in there. We know that we're seeing issues in our own schools locally. They're not making as many of the headlines there going on, but recently in Galveston, for example, when Galveston PD went after federal charges, in fact, local charges, felony charges, and the federal government's looking at it too, in which 2 deaths of foreign nationals who were here in our country working on a visa, both were at the same party. Both took drugs that they did. Yeah, Christmas Eve. Oh, that's true. That's right. Both of them took drugs that were at the party. It didn't look like drugs. And that's the thing I use the term of, doesn't look like cocaine, doesn't look like heroin. It's just pills. And I say just pills, but then they're both dead. And one of the I found amazing about this too is, and I was going to ask you about this before we go in, is that working with the district attorney, working with the DEA, Galveston PD was the first I saw that really went after the dealer here and said, you murdered these two guys. And they filed homicide charges, murder charges against them. Do you think that is going to help some? Because in addiction research, you're looking at ways to get people better, but at the same time, there's that law enforcement component. And how do you see that as helping combat this problem?
Well, we need to get these street drugs off. We need to get them off the street. How do we do that? Unfortunately, people are dying. That's balanced with harm reduction methods and with knowledge, and understanding what we're looking at and being alert to what your children are doing, what your spouses and your friends are doing, and being informed well enough to be helpful with scientific knowledge on my perspective.
Right. And again, this is another chart you had here that these are you have Xanax, a counterfeit version of Xanax, real Adderall versus counterfeit. That this is something that parents probably need to be looking for. Don't just think. One of the things I learned from the DA when talking about this is some of these look like Pez.
Yes.
They look like Pez candies. Yeah.
And they sell them multicolored candy-looking pills that they can sell to kids.
And you can't detect it.
No.
Just by looking at it.
Not without sophisticated analytical tools. You can't taste it, you can't smell it, and you don't want to taste it, honestly.
Right, because the idea of dipping your finger in, putting it on your tongue, oh, that's cocaine or whatever. You don't want to do that here because you can be in the world of hurt.
And I'd like to add that on the screen there's a very another very marked statistic, which is the DEA tests everything that they pick up that is being trafficked in our country. And in 2021, I think that says. Yeah. 40% of the pills that they tested had fentanyl in them. 1 year later, 2022, 60% are fentanyl positive. That means more potentially lethal drugs are out there 1 year later.
Oh my goodness.
Yeah.
It is something, and I said it's scary for that. And when we come back, we're going to talk to another expert in combating addiction, but also to a former addict who had to beat this back and is now himself helping people in the world get over that. And we'll have that coming up right after these words from UTMB Health.
UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com.
Welcome back to Healthcare Unmasked, presented by UTMB Health. We're talking about the issues of opioid addiction as well as fentanyl poisoning and how we can combat that. And joining us now with us is Dr. David Houghton. He is a clinical psychological scientist who conducts research on the causes and treatments of compulsive and addictive behaviors. And then also joining us, and I really appreciate him being with us, is Chris Lewis. Now, he's a research technician for the Center for Addiction Research here at UTMB Health. But his interest came about it in a different way, is that he himself had experienced addiction and from between 20 and 30 years old. And hey, Chris, I wanted to hear your story here first, if you don't mind, just because now you're out there really, trying to combat, the addiction problem as you're seeing it there. talk about your own experience and how that's in many ways kind of measured what you are now trying to do.
Yeah, well, I mean, I think myself, like many others, when you begin the process of taking an opioid, self-medicating, or for whatever reason, over time, you just become more addicted, and you find yourself addicted before you even really understand what that means. Because I was about 20 years old and I had a football injury, and so I was already kind of primed to like enjoy taking them. But my understanding of addiction was very elementary. And so I just kept taking them. And then one day I woke up and I couldn't keep my body still. And so as soon as that happened, I realized I needed treatment. And so I went and I got on buprenorphine for a period of time. I could never really stay on many of the medication assisted treatments. I was on methadone for a while as well. But it was just a constant push and pull. I detoxed myself and then I'd go right back. I was using through the fentanyl epidemic, so I know how a lot of those go. There are a couple points on that I wanted to touch on as well a little bit later, if that's all right.
Yeah, we're gonna give you plenty of time to do that.
Okay, yeah, because I mean, if you can pull up the map of the overdose deaths.
Yeah, let me bring that up right now.
Okay.
There we go.
So as Kathryn was mentioning, between like 2015 and 2018, a lot of the active pharmaceutical ingredients were coming from China. So they were coming in through the ports. And you can see in the left-hand map, San Francisco is one of the ports. New York is another one of the ports, and then Chicago. So those are all the hot spots. And then flash forward to 2018 and on, a lot of those precursor chemicals, as Kathryn mentioned, are being sent to Mexico for the cartels to make and then put into pills. So now you can clearly see the trend. And then if you see on the overdose death rates between 2018, there's a little lull at one point, and then it takes off. And it's almost like COVID happened, as well as the cartels amping up production. And so this is going to become a bigger issue as time goes on. And it's something that we need to create more methods to combat addiction in people.
And it goes into what we were talking about before, Kathryn, is that the opportunity arose there. And it was like a perfect storm. People locked up at home. One of the concerns about when we had the COVID lockdowns, one of the first concerns I heard from a lot of folks in your role and addiction care centers and like is, we are about to lose a lot of people we've been helping. And as Chris just pointed out, that happened. And it is still happening. And there's a catch-up happening right now. And at the same time, the guys making the stuff that's out there killing people up their production because they realize we have the rebounders. Folks have fallen off the wagon, as the term would be used, and re-addicted. We got them. It's like a new customer base all of a sudden after they'd lost them.
The stress and anxiety of the pandemic definitely played a huge contribution to the rise in overdose deaths and poisonings. One thing Chris is a living example, though, of being able to seek and establish the comprehensive care it took for him to recover. And I applaud him for speaking out. Thank you, Chris. And also represents what you can do with your lives. And it doesn't mean if you started off that way as a youngster that you have to end up that way.
Right. And it can be beat, as Chris is obviously an example of here. But I would take it, Chris, it's something that you've got to be focused on every day, right?
Yeah, I mean, after a period of time and psychotherapy, it's very easy to manage, after some time. But no, I mean, it took. So I would also like to address the fact that I had the financial means. I had a family who was educated, so they were open to hearing about new treatment ideas and things like that. So it goes to the point of we need to expand access to those less fortunate so that they can get the same opportunities that I was afforded. Because I think that
Thank you.
Yeah, I think that's important to mention, and we're going to be. Let me go ahead and we'll just bring up the stigma side of things. And joining us also too is Dr. David Houghton. He is a clinical psychological scientist who does researches on treatments of compulsive and addictive behaviors. And Dr. Cunningham and Dr. Houghton, I want to talk to y'all about this. Is the you just heard from Chris here that hey, I wasn't poor, I had a strong family, everything else that's there. And we have this stigma, I think, as a society, that when we hear people who get addicted to drugs of any sort, that they're the people on the street corners, or they're under the bridge, or they're, in the poorer neighborhoods. That's just not true. Is that right, Dr. Houghton?
Correct. I think that we have a troubling and long-lasting legacy of blaming drug users for their problems. We tend to see it as an issue of personal responsibility, and that if you're a responsible person, the idea is that you probably shouldn't take drugs in the first place, or if you do, you need to manage your use and keep the functional aspects of your life alive. And unfortunately, this is just a very pervasive attitude that prevents people from getting help, prevents people from accessing a community of support around them, and leads folks to I think a further downward spiral.
And let me ask you this, because Chris, again, I echo what Dr. Cunningham had said. You're so brave coming on and explaining this here. One of the things too, Dr. Houghton, you talk about that we seem to take a look at it as personal responsibility, but also the treatment plans for the longest time is kind of a cookie cutter approach for the longest time. You are experienced in making sure, no, we need to customize this for each individual because they have an individual addiction problem. Can you talk more about that? Because I think that's something that gets lost on people saying, the old days of thinking, and I say old days because, the thought of dealing with addiction is, I think the first time our nation really kind of heard about this was Betty Ford. It's like, all right, we're all going to go to the Betty Ford clinic and we're going to get better. We're going to get over alcohol. We have AA where we're going to do, the 12-step program and the like. But you really need to get more individual. It is about the individual than it is about this is how you beat it for everybody.
Absolutely. We're learning that more and more. And I think that's a attitude that's sort of cutting across medicine, that we're starting to try to see people more as individuals and not just as suffering from a problem that has one cause and one treatment. In the addiction world, in the substance use community, where we see that is the history of treatment is generally geared around 12-step abstinence-only approaches. The idea basically is that you have a problem and you need to be the one that fixes it. And the only way to fix it is to become 100% clean and sober. And that's a decent approach for a good amount of people. But it doesn't work for everybody. If we look at the limited data that we have on the success rates of abstinence-only approaches, they're not very good. It's probably less than 10% of people who are going to have success with those approaches. So the obvious answer is we need to be doing more. It's not people's fault that they can't get better. We just don't have a lot of range of treatment options available. In fact, we only have several medications that are effective for substance use disorders. We have some for opioid use and some for alcohol abuse. We do not have an effective medication for cocaine or marijuana or methamphetamine dependence. So it's a problem.
Yeah, it is. And Dr. Cunningham, it goes into, more resources need to be dedicated to this. But now to dedicate those resources, it takes money. Mm-hmm. And Dr. Houghton, you brought up something. If you're going to be an individual approach to things, that means more time with some versus others. And I think we've seen this in the education system of not just dealing with education overall. It's like the idea of 30 kids in one room and they're all going to learn the same thing at the same pace. That's been debunked a long time ago, but that still becomes the model in many ways. Whereas in this case too, it is you need to get to that more individual education, because it is education, is it not, Dr. Houghton? It's an education to how to combat your addictions in this case and
Yeah.
understand more about it, is it not?
Absolutely. I think that when I hear from individuals in the community, I mean, if you're a psychologist, people will ask you these sort of questions, like, hey, what should my friend or what should I do about this problem? Most people don't know where to start. They sort of say, I've never thought about having to navigate the healthcare system, having a problem like this. Is my insurance going to pay for care? What kind of care are they going to pay for? Are they going to pay for a psychiatrist, psychologist, a social worker? Is that going to be outpatient treatment or inpatient treatment? And the consequences of navigating this the wrong way are pretty significant. If you can't find a covered provider, you're looking at a lot of money out of pocket. So simply giving people the resources and the knowledge of how to navigate the healthcare community is absolutely what we should be investing more in, but people don't know.
But it also gets into something too, Dr. Cunningham, is that the medical community, you would argue, needs to catch up as well and recognize these problems at a different level than, oh, now I have this problem, I'm gonna go to this specialist for it. It needs to be a more all-in approach, top to bottom, is it not?
Yeah, in the ideal world, what David was saying was that we need comprehensive substance use disorder treatments. And that entails psychosocial support, it entails medications that can be useful, and it entails medical care and community support. So the whole picture ideally is integrated together so that there's a program that is navigated by a patient. And I believe that we can do better, and I believe that the force is with us right now. That I think there's a lot of interest in being able to pull together that. In Galveston County, as I mentioned, we have amazing resources here, people and services and real skills that come together to help a person. So I'm very optimistic. I'm a little worried still about fentanyl, but I'm very optimistic that we can do a better job, like David was saying, of treatment for SUDs.
And one of the things you brought up the other day is that there actually is kind of a coalition now that is formed up to help that. Talk about that.
So the coalition is it's forming now, and it has approximately 40 entities involved in the program. I believe the first meeting will happen in March. I'm not remembering the dates, but the concept is to mobilize the community to make sure that we are covering our bases with understanding how the community is dealing with poisoning, drug overdose and poisoning, as well as trying to do a better job of integrating those treatment facilities and what interesting new and innovative models can we platform here. And
this coalition is a combination of medical experts, social services, law enforcement as well. And remind me again the name of it is an acronym. It's kind of like still evolving the name, but Galveston County Coalition is Coalition. Gotcha. Yeah. And it really is it's going to be a kind of an all-in approach. And I see the opportunity from what you explained to me the other day. It is, fentanyl is a problem right now, but there's going to be something else down the line. And having this type of coalition together can adjust as whatever the local community has to combat.
Yeah, the downturn is beginning. I think getting through COVID, but we still have to deal with fentanyl on the streets. And until we do that, we're going to use a lot more young people and productive young people.
One of the things that I found interesting, and it's been in the news a little bit for a different reason, but there's been an ongoing issue of looking into the vaping drugs, the cartridges, and mainly because of THC is obviously, no one can legally buy THC over 3%, I should say, that's out there that now they're finding in these cartridges, those vaping cartridges, there's not just THC over, a certain amount, but also that fentanyl's getting placed in that too. And so, the what would have been thought of, okay, it's vaping, basically THC, for those who don't know, it's the compound inside marijuana, the cannabis that that gives you the high feeling, that like, oh, that can't be that dangerous, until you realize if it's getting a few grams of fentanyl in there, it's really risky.
Yeah, it's either even scattered reports that marijuana itself is being laced with fentanyl, although depending on what you read, it's not clear what the magnitude of that problem is, but I would certainly consider that
Right.
as a possibility.
And also too, and again, we say street drugs. I wonder if does that contribute to that stigma? We'll say street drugs, and then it's like the seedy side of the road type of thing, when it's actually a bigger thing.
Actually,
So,
I do agree with that, but honestly, I've been racking my brain and reading
of finding
literature for
something a better line,
else.
right? Yeah.
I mean, they are on the street, and I don't mean that to be stigmatizing, but
right.
The one thing to note is how do they find kids, and one of the places they find them is social media.
Right.
And unfortunately, I have a good friend who's her close friend actually died of pills that she got on Craigslist or one of the online venues.
Right.
So how do we stop that? That's another sort of unregulated source for drugs for kids. Twitter.
Yeah.
Other social media.
TikTok. I mean, we just had, I know that we've been working with the Organized Crime Task Force, in Galveston County for over a year now at I-45 now, where we've been able to, take a closer look at this, and it is something that how the marketing of it is done, and it is marketing. It's influencers come in all forms. Drug dealers are influencers now too, and I wanted to share this because we had Chris talking about his personal story. And Chris, you brought up something that was interesting for me personally to hear you say, is that, hey, it wasn't like I was some guy who's strung out the side of the road or under a bridge or something like that. Hey, you had financial resources, you had a family support and stuff. And I should point out too, my own personal story with this, and I've shared this to a lot of folks, is that it's not a secret that I had crushed both my legs back in 2016, and then one of the pain meds supplied to me was an opioid, taking it as prescribed. Kept going, and he was like, and then finally I was like, well, I really don't need these anymore now. And I did you talk about self detox, Chris. I mean, my self detox was a cold turkey move. Now which threw me in this whole kind
Painful.
of spin by itself. Mm-hmm. And here it is, good job, great insurance, family support, and because of the community I live in and what I do for a living, I can make a phone call to about anyone, including you now, but to say, hey, I need help. And I did that, but not before I realized I had made a huge mistake going cold turkey, and my body had found itself addicted to. So when you say addiction, it's Dr. Houghton, you said it. We tend to stigmatize and say, hey, this is a self-choice thing here. I was following my doctor's orders, my doctor's instructions. It still happened to me. That's part of this that gets lost, does it not?
Absolutely. There are so many ways that one can develop a drug or alcohol problem. There's no one size fits all sort of explanation for it to say like, oh, you just behaved irresponsibly and now here you are. Many people can develop a use problem through no fault of their own. Absolutely. The question is, we should not be asking how you got into that situation. It should just be, how do we get you out of that situation?
It's been, in fact, as I said before we did this show today, that we would be having we could go on for 4 hours, I think, and still not touch everything. But we do only have about 10 minutes left. We're going to take a quick break. When we come back, we're going to have some final thoughts, including, by the way, we talk about, hey, where do you start for your resources? That's one of the things we're going to be addressing when we come back here. You're watching UTMB Healthcare Unmasked.
UTMB knows when you're expecting, you may not know exactly what to expect. From that first embrace to all the milestones that follow, we know how important each stage of life is. That's why UTMB Health's obstetrics and gynecology physicians specialize in innovative women's health care through all phases of life. UTMB knows women's health. UTMB knows you. To find an OBGYN specialist near you, visit utmbhealth.com/women's.
And welcome back to Healthcare Unmasked. I'm TJ Alls, along with Dr. Kathryn Cunningham. Also joining us is Chris Lewis and Dr. David Houghton, who are sharing their experiences with us as well here. We've just got a few minutes left on of the program here, and we're going to have y'all all back at some point, I think, as well. Not I think, I know so. So y'all are committed. Sorry, I've just committed y'all all for this. But one of the things, and we had done a story about this recently, Dr. Cunningham, was the fact of having things available that can help you. One of those things is Narcan. Let's hold up that box again here so you can. I'm gonna put you on camera a little closer here. No, it's me. There it goes. This is available right now. Maybe not in the greatest of supply. Talk about what Narcan is able to do to help out.
So at the beginning, I mentioned that these are opiate derivatives, and opiate derivatives work on opiate receptors. And so that's true in the respiratory system, which causes death. So if you OD or get poisoned on opiates, then Narcan, which is actually the drug naloxone, blocks those opiate receptors and terminates the action of the fentanyls or other opiates in the system. And it is life-saving. It is available you can walk into a CVS or a Walgreens, I believe, and you can purchase it, but it costs money. Or if you have insurance, you can get some of that money, some of that covered. We are, the Galveston County Coalition, are working along with a lot of other people in our community to attempt getting more Narcan out there. Right now it's available at the one
Heart Pharmacy, right, in Lamarck.
In Lamarck, and it's a walk-in and walk-out with it for free. So we are the backlog on getting Narcan is a bit of a problem now, but we have many cases in delivery throughout the community. And there are these angels of mercy that are taking them around and making them accessible. And so I think, and training, you do need to have some training. So that part, it's straightforward, but under a circumstance of an emergency, sometimes your
right.
capabilities are maybe not as strong. So,
and in fact, you were trying to work on an effort since Mardi Gras had kicked off this last weekend of having this available, but the supply is pretty short right now.
We've got some now, and we are still planning on Saturday during the day to set up a information knowledge station and distribute what Narcan we do have as a public courtesy effort amongst a lot of people in the community who want to see more information out there and more accessibility of Narcan.
And one of the things we wanted to also talk about is the wearable device study.
Oh yeah,
that's taking place. Let's talk about that because this is really interesting.
Yeah,
really fascinating.
David. So one of the things you mentioned, if you could bring David back,
yeah.
One of the things you mentioned was how physically debilitating the withdrawal syndrome was when you were trying to stop.
Right.
Right. So David can explain this clinical trial that's set to start in a month or so.
Yeah, absolutely. So just like you described, TJ, that when you've been taking an opioid for quite a long time, it's very difficult to get off because your body does become physically dependent on it. Just like it does to many other things. If you're a regular coffee drinker and you stop drinking coffee, you're going to get some headaches. So with persons who have chronic pain, who rely on opioids for pain management, in many cases, over the course of their illness, their doctor might recommend that you should probably take less medication. For a variety of reasons, let's take your medication down or switch you to a different type of medication. Now, for a patient, that's really intimidating. Wait, you're telling me I have to go off this drug? I'm gonna feel like a lot more pain, and I'm gonna get these withdrawal symptoms. So it's not a very easy thing to do. What we're pioneering is a new brain stimulation device that fits over the external ear and stimulates the vagal and trigeminal nerves. And we have preliminary evidence that this does a really good job at reducing withdrawal symptoms and pain. So we're currently engaging in a mechanistic clinical trial that will be looking at the underlying brain mechanisms of why this device works, with the idea of optimizing it for real world clinical implementation.
That's fascinating. It kind of reminded me when you first explained this to me of, when you actually say you've after had surgery and you're laying in your hospital bed and you have your pain meds there, you can push your button when you need it. But when it hits a certain amount,
It's over.
you ain't getting any more. You can hit that button all you want and think you got a placebo effect going on. It would help in that way, is just being able to gauge this more controllable, make it out there. And how and again, I know you said the stress. Where are we in this research, and when do you think we're going to see some practical use?
Sure. This is a multi-site study. We partnered with the Medical University of South Carolina and Spark Biomedical, who produce these devices. We are just about to start data collection, so we will have individuals who use opioids for chronic pain enrolling in the study within a matter of a week or two.
That's a week or two. Wow. That's going to be something else. Well, we need to do a follow-up on that for sure. There. Before we wrap up here with final thoughts from everyone, Chris, I wanted to go back to you here real quick. What convinced you after what you'd gone through, you wanted to make sure that, hey, I want to make sure this doesn't happen to other people, and you joined up here at UTMB to help combat that?
I spent a lot of time. I faced a lot of stigma, not from my family, but from people around me. And I just realized that, this is an issue that needs a lot more research, and with more research, more solutions come, and this becomes less of a nightmare scenario. It's more something that can be managed through basic treatments. I mean, just as with many illnesses in the past that we've overcome with medications, this can be done just the same.
And you had said it there. It goes into, I think, the reinforce what you said, Dr. Cunningham, and what you said, Dr. Houghton, is that you put the resources in there, it works. There's proof that you put the resources to combat this, it works. But that becomes that becomes the rub. It is, how do you get those resources there?
I feel if anything comes out of what's going on right now, that there is a renewed interest in understanding and treating substance use disorders, not only making sure overdoses are not happening, but actually helping people fulfill their lives. And so that's what we hope to accomplish through our efforts at UTMB and in the community. So we'll see how that goes.
Right. And it does. And one of the things, and I know I don't want to put anyone here in a tough position, so I'll say it. It gets into is that part of that stigma we got to kind of replace is there's the money driven side of this, that we could have a lot more of this available if production ramped up. Now, I'm not trying to blame anyone here, but this Narcan is not as profitable as, let's just say it straight up, Viagra or Cialis. Not as big of a profit margin on this combat, and there's in many ways because of the stigma of drug addiction. That so what we probably need to kind of focus on is that there's not going to be just that one silver bullet, just like battling addiction. There's not the one silver bullet. There's not the one. So it's not just a legislative thing. It is not just a societal thing. It's not just law enforcement. It is not just the drug companies. It is everyone saying this is a priority. Am I making it a priority? If we make this a priority, it makes the others a priority too. Would our two doctors agree with that?
Well said.
Right.
Absolutely. Couldn't say it better.
Well, and then now let's, one of the things is we've talked a lot about addiction research and about what you're doing here, but tell folks about the Center for Addiction Research, because there's a lot on this here, but we have a website you can go to. You can reach out to y'all as well. Talk about the center, what it really does, and what it's trying to create here.
So the Center for Addiction Research is about 14 years old, and the topic of is addiction, but we are focused on trying to understand the mechanisms, the changes that occur that contribute to addictive disorders and other mental health disorders, and what the precursors of that are, such as trauma. Is a big driver of the use of substances and the development of substance use disorders. So we're very interested in that, what David was saying about personalized medicine, and how do we approach that to a better efficacy in all patients. And some of the work we do is medications and drug discovery. So we probably have 12 patents that are focused on novel therapeutics for substance use disorder or other neuro disorders. So that's one. The research part of it is best described as translational, which means it crosses the research from basic to clinical. And then we have a large focus on education and community outreach, the next generation of scientists, and also the community in helping to deal with problems that we've been talking about here today. So we do have a website, and it does have a UTMB address that is monitored. So please don't hesitate to reach out.
In fact, we have that. If you look in the comment sections, folks, you can see that we have the website link right there for you to go to. It's utmb.edu/CAR. That's not CAR. That's Center for Addiction Research. There. So, but it's easy to remember. utmb.edu/CAR, and you can find out more. But it also gets into what resources are available. We've talked a lot about, hey, what should be done, Dr. Houghton and Dr. Cunningham. But what if I have a family member or I'm a viewer here and I'm trying to figure out what to do with something that's happening in my life along this one way or another, where do we start? Where do they go? What number do they call? Is that resource up and running yet? And if not, when do we think what it's going to take to get that up and running?
Well, I think I could answer a lot of that question with more time than I think we have. But I think one thing to do is think about having Narcan in your car and nearby when you are, and if you know your kids have dabbling in anything, make sure that they have access to it, or it's around where they are, and just make sure that it is available. And it is free. You can go online and order it. And there is training in Galveston County right now. So we can easily link you up with those. Many of our students and postdocs and faculty are doing those trainings. So I'm very proud of their efforts.
Well, and I should commend UTMB Health, because this will be, this is another session we've had. We've been part of at I-45 now, a couple of sessions, public sessions, and we streamed one with working with the Bay Area Alliance for families on this topic, and had really good session. We had a good crowd there in Friendswood, and want to thank Friendswood ISD for helping us with that. But this is the type of information we need to get out, and it is not just dealing with what we're talking about here. These type of processes, what we're talking about, individual treatment, having the resources out there and all, can be anything as we face any more of epidemics or drug problems down the line. And I think Chris's line was the best, is if you take the steps to get it to combat this, it actually becomes pretty easy after a while, right?
And I'd like to add, you said you went cold turkey. Many times cold turkeying was way more difficult for me than weaning. So trusting your body and seeing what works for you is something I would definitely recommend as well.
That was a wake-up call for sure, because I'm a lot more cognizant of what I'm putting in my body now when it comes to pills. Obviously, with my size, I'm not that way about food. But anyway, but it is something to make loose. And as I pointed out too, with my story here, is that, as every physician has treated me since, is that it changed my body chemistry. There are problems I have now from that episode. from there. And because I could have had the knowledge, but I didn't have the exact knowledge for it. And I think part of it's the stigma. I knew there was a problem happening, and so I figured I can handle it on my own. And that's where it kind of starts a lot of times for folks. That self-medicating then becomes a problem, that becomes that big monkey on their back that they can't combat. But there is help out there, and we should, as a society, not look at everyone and say, "Oh, I had addiction." Look down our nose to them. It's a problem like any other that needs to be combated, and people need that support. I would take it, Chris, for you, when you got the support, that was the big thing that helped.
Yeah, definitely.
Gotcha. Well, y'all, it's been a fascinating topic. Thank y'all so much. And
thank you for inviting us.
It has been, and we will combat this, at least in our way of putting stuff out there. Information, I always say, is the best way of doing that. Dr. Houghton, thank you. Any final words from you before we wrap up here today?
I'll just say people use drugs. It's part of our society, and we're just doing the best we can to help folks out. So thank you for having me, TJ.
And all of our resources are on there for you to find out more from UTMB Health. You can find it in the comment section. Final words from you, Dr. Cunningham.
I really appreciate the opportunity to talk about this serious, critical problem. And I look forward to meeting some of the folks online as we build these coalitions to manage this problem.
Well, and next time around, we're going to have one of these. We're going to really do some, really ask people to come in and give us questions and answer. We wanted to kind of really have an overview here, get some information to you, some links to you as well. But as we talked about, treatment need to be individual. Sometimes the questions are individual, and people are afraid sometimes to ask these questions and have their names out there. We understand that. So we're going to find a way the next time we do this you can ask questions and do it anonymously, so we don't pop your name up on screen or anything like that. I know that we would help, so we will do that as well. Thanks again, and thanks again to UTMB Health, Raymond Kern and his crew getting our new studio set up here. We've got a few things we're going to make, but it's great to have it. So I appreciate everyone watching. I appreciate our guests on with us here today, and tune in with us next month for Healthcare Unmasked, presented by UTMB Health.